Today we'll be discussing physiology of parturition, the breast, and lactation. At the end of this section on parturition, you should be able to describe the 4 phases of parturition, including the roles of oxytocin and the prostaglandins. You should be able to explain the site-specific control of myometrial contractions and cervical dilation, explain the changes that occur during the 3 stages of labor, which occur during phase 3 of parturition, and you should be able to summarize the changes that occur during the postpartum period. The 4 phases of parturition. Phase 1 is considered quiescence, and this really includes the entire prelude to birth and is approximately 95% of gestation. This includes a period from the time of fertilization and implantation all the way through the actual preparation of birth, and it does comprise approximately 32 to 34 weeks of pregnancy. During this time, note that progesterone is the primary hormone, and it acts predominantly by binding to its receptors and suppressing myometrial contractions. Phase 2 of parturition is the preparation of birth, and during this phase, gap junctions form between the myocytes and myometrium, which in essence transforms the myometrium into a large syncytium. At this time, there's also what we believe to be a local change in the estrogen to progesterone ratio. This ratio has not been demonstrated to occur in primates, but it has been shown to occur in other species, and therefore we do believe it also occurs in women and non-human primates. Phase 3 is the actual process of birth. This includes labor and delivery, strong myometrial contractions, which are regulated predominantly by prostaglandins and oxytocin, the Ferguson reflex, which is the neuroendocrine regulation and release of oxytocin, coupled with cervical dilation, which is predominantly mediated by prostaglandin E and associated with breakdown of the cervical plug, which was induced and formed during the high levels of progesterone during the quiescent, i.e. or phase 1, and the tissue breakdown is predominantly mediated by matrix metalloproteinases. Phase 4, or the final phase of parturition, is typically considered the recovery from birth. During this time, the levels of oxytocin are typically still elevated, and this acts to cause vasoconstriction of the very highly flowed uterine arteries. At this time, we also have immune cell recruitment into the uterus and other reproductive tissues, i.e. typically referred to as cleanup duty, to make sure that infection and sepsis do not occur. Image on the left shows oxytocin, which is a nanopeptide, and image on the right shows the prostaglandin pathway of production. Just recall that it starts with phospholipids and arachidonic acid, and PGH2 is the primary precursor that gives rise to all of the other active prostaglandins. Speaking about oxytocin, it is considered the primary molecule that drives myometrial contractions during parturition. It is the most potent uterotonic agent known. We know that the frequency and amplitude of oxytocin-induced uterine contractions are identical to those seen during normal labor. Uterine contractions can be induced with electrical stimulation of the posterior pituitary or manual stimulation of the nipple, i.e. 2 actions that are known to cause the release of oxytocin from the brain. And other studies with drugs also indicate that oxytocin is involved. In Europe, an oxytocin receptor antagonist, i.e. atosaban, can effectively inhibit preterm labor, and beta-parasympathetomimic drugs, such as terbutaline, are the first drugs typically administered in the U.S., either through IV and or short-term use. Recognize that it's not just the concentration of oxytocin that's important for parturition, but it is also time-dependent due to the upregulation of the oxytocin receptors. And this leads to a dramatic dose-dependent response throughout gestation. As noted in the table, the non-pregnant dose of oxytocin required to induce contractions is 100 milliunits per minute. Looking at the term uterus, or approximately 38 to 40 weeks, it takes 100-fold less, or 1 milliunit per minute, to cause the same dramatic contraction of the uterine body. Okay, so the key point to this is that the temporal and dose-dependent responses to oxytocin are due to increasing numbers of oxytocin receptors in the myometrium. Going back to one of the earlier slides where we talked about the estrogen and progesterone ratio, we believe this occurs because estrogen is known to upregulate oxytocin receptors, whereby progesterone is known to downregulate oxytocin receptors. Thus, although progesterone effects are evident during the first 32 weeks, we know that increasing concentrations of estrogen, potentially even estriol, which is the estrogen of pregnancy, may be helping to upregulate oxytocin receptors in this muscle. There's also very strong evidence that the prostaglandins, predominantly prostaglandin E and F, are also required for parturition, and there are multiple lines of evidence. We know that cyclooxygenase inhibitors, including indomethacin, can inhibit myometrial contractility. We know that if we deliver PGF2 alpha or PGE2, we can stimulate uterine contractility in women and non-human primates. And we also recognize that prostaglandin production increases at the time of labor and not before. As demonstrated in the histogram, note that both PGE2 and PGF2 rise dramatically in the amniotic fluids during labor, but not previous. Although not indicated on the slide, we also know that uterine infections, which lead to the inflammatory response and upregulation of the prostaglandins, can also be a cause for preterm labor, thereby also supporting the role of prostaglandins during parturition. Collectively looking at this, the temporal-spatial distribution of the oxytocin and prostaglandin receptors allows for both uterine contraction and cervical relaxation at the same time. Key point number 1. Upregulation of the oxytocin and PG receptors at term is requisite for parturition. Key point 2. Uterine contraction and dilation of the cervix, otherwise known as cervical ripening, are highly dependent on the tissue-specific distribution and or expression of the oxytocin and prostaglandin receptors. And key point number 3, we know that uterine contractions are primarily due to the actions of oxytocin and prostaglandin F, whereas cervical ripening is due to the actions of PGE and the MMPs. Prostaglandin F receptors, otherwise known as FP, and the oxytocin receptor, otherwise known as OTRs, induce strong muscle contractions and or vasoconstrictions. We know that the oxytocin receptor is inhibited by progesterone, and the mRNA is upregulated by estradiol. We know that both of these receptors are stimulated by calcium mobilization. Prostaglandin E, on the other hand, can stimulate both contraction or dilation depending on which receptor it binds with. So the EP1 and the EP3 receptors are very similar to the FP and oxytocin receptors in that binding with these receptors will cause contraction. On the other hand, when PGE binds with either the EP2 or EP4 receptors, this will cause smooth muscle relaxation, and when those receptors are localized to smooth muscle vascular cells, it will lead to vasodilation. Going a bit more in detail now into site-specific physiological control of contractions and dilation. First, remember that the myometrium is composed of multiple zones, and that the innermost zone of the myometrium is referred to as the junctional zone. And the junctional zone, recall, is very densely packed with myocytes and therefore can induce very strong contractions. We know that the JZ is stimulated during parturition. During phase 1 of parturition, when the myometrium is relatively quiescent, we know that it is progesterone and PGE2 acting predominantly in a synergistic manner to calm the uterus. So both progesterone and PGE2 maintain relaxed tone and inhibit contractions. We know that the progesterone receptor, the nuclear form, is located throughout the myometrium. We also know that the EP2 receptor is especially high in the junctional zone. And additionally, we also know that we have very low levels of the contractile isoform of the PGE2 receptor, both EP1 and EP3. Recent studies have further demonstrated that we also have membrane-bound progesterone receptor, predominantly the PGRMCs, which are localized in very high levels in the junctional zone, thereby giving progesterone two mechanisms of action to cause quiescence and calm the myometrium. As pregnancy progresses, we now see that the oxytocin receptor numbers increase, thereby preparing the uterus for myometrial contractions and parturition. So in the fundus and upper segment, we see a loss or a decrease of PR. And when we lose PR, we typically also see a loss of membrane-bound progesterone receptor, predominantly PGRMC1. And collectively, that leads to an upregulation of oxytocin. Recognize that even if progesterone levels do not fall locally, the inability of progesterone to act also predominantly preferentially prefers the actions of estrogen, which can also lead to the upregulation of oxytocin receptor. When the oxytocin receptor reaches a threshold, it will bind oxytocin and start to cause contractions. In the lower segment, we only see a slight increase in the oxytocin receptor, which is logical, being that this segment will have to relax to allow passage of the baby through the birth canal. And in the cervix, we find absolutely no oxytocin receptor, and or also EP1 or EP3, thereby not allowing the prostaglandin E to cause contractions. When we look at the EP and FP receptors, we also know that they are involved. Note that the EP2 receptor is localized predominantly, as we mentioned before, in the junctional zone, which is causing predominantly quiescence and relaxation. As we prepare for birth, moving into phase 2 and phase 3 of parturition, we do see an upregulation of the prostaglandin F receptors in the outer myometrium, thereby providing another mechanism for contractility. In the upper fundus, we see an upregulation of EP3 and FP, which now will allow prostaglandin E to also contribute to contractility. In the upper segment, we see again both EP3 and FP. So collectively, in the outer myometrium, especially in the fundal and upper segment regions, we see upregulated levels of both EP3, prostaglandin F receptor FP, and oxytocin receptor as demonstrated on the previous slide. Importantly, recognize that the upper segment in the fundus will need to contract. Concomitantly, we will need to see the lower segment in cervix relax. And in the lower segment in cervix, we see an upregulation of EP4 and even higher levels of EP2, suggesting that prostaglandin E is the primary hormone driving relaxation of that region. We also see very low levels of FP, thereby, even if we do have escape of prostaglandin F into the vessels and tissues of the lower segment and cervix, we will not have very much contractility action. We do know that the fetus and the tissues of the fetal body, such as the amnion, will contribute to increased contractility during parturition. And we see that EP1, EP3, and FP are all upregulated in the amnion itself during labor. The decidua does not typically exhibit very much contractility or vasodilation during this time, suggesting that the decidua itself does not necessarily contribute overly too much to contractility or relaxation. Thinking about the actual process, recognize that strong contractions begin in the fundus and radiate downwards towards the cervix, and this is predominantly due to the spatial distribution of OTR, EP, and FP receptors, and EP predominantly EP1 and EP3. So collectively, looking at this in illustrated form, there are 3 primary contractile receptors. Okay. And at the lower end, towards the lower segment in cervix, we see strong upregulation of EP2 and EP4, which will provide relaxation, thereby opening the birth canal and allowing the contractions to forcefully push the baby through the birth canal. Okay. Recognize that contractions are thought to be initiated when oxytocin levels bind to high levels of OTR in the fundus. There does appear to be a threshold. And these contractile waves then radiate downward towards the cervix. These contractile waves will increase in both frequency and amplitude, i.e., the contractions are coming closer together. And recognize that not only do we need relaxation of the lower segment and cervix, but the entire uterus must relax, or that constant contractile force could crush the baby. Okay, so yes, Oxytocin is causing contractions, but recall that it is being released predominantly in a pulsatile manner. This does allow the uterus to relax. There's also some upregulation of EP2 in the fundal and upper segment layers, and this in itself will also counteract the effects of binding with EP3 to help induce relaxation. As labor progresses, levels of oxytocin and PGF increase, and thereby we will increase contraction intensity, leading concomitantly with a decreased net relaxation, at least in the fundus and upper segment. Note that very importantly, measuring contractions is critical, because if we do have continuous contraction, this will cause uterine tetany, which is life-threatening to the fetus and can cause significant morbidity and potentially mortality to mom. One thing that must be discussed, as we talked about in the physiology of pregnancy, recall that progesterone causes thickening of the cervical mucus in general, and that during pregnancy a very thick cervical mucus plug is formed, thereby preventing pathogens from entering the birth canal and also holding back any liquid, i.e. and or fetal constraint. This plug must be degraded and broken down before parturition can ensue. This is predominantly done through the actions of MMPs, whereby this plug, which is collagen rich, will be degraded. Okay. The MMPs are stimulated during parturition, which will allow the cervix to dilate. In summary, we have looked at the MMPs through multiple processes in female reproductive function. Recognize this is a relatively large family of proteolytic enzymes. They do regulate turnover and remodeling of the entire extracellular matrix. They're multiple and various in their functions. They degrade collagen, stromolysins, laminins, etc., and they are inhibited by the TIMPs. There are at least 3 TIMPs that we are aware of. Looking at this from a tissue or organ-specific process, recall that in the ovary, the MMPs are involved with ovulation. This releases the oocyte complex, and it's involved with fibrinolysis of the follicle wall. In the endometrium, the MMPs are upregulated during both menstruation and implantation. During menstruation, we have the breakdown of the entire functionalis layer. It's also involved with vascular remodeling immediately during and before and after. And during implantation, we also have MMPs released during invasion of the blastocyst and some vascular remodeling of the spiral arteries. And obviously during cervix. In the cervix, during parturition, we have breakdown of the MMPs of the cervical plug, leading to dilation and cervical ripening. Now, a question that remains is what actually determines the onset of labor? Historically, in sheep and other domestic livestock species, it's been relatively well shown that cortisol coming from the fetus is most likely a trigger and potentially the final trigger that simulates uterine contractions at birth. This has not been conclusively demonstrated in non-human primates and or women, but it is thought to be a primary mechanism of action, and it is thought by most clinicians and or basic scientists studying reproductive physiology that the fetus is predominantly the main stimulus for when parturition actually starts. However, in addition to the adrenal axis, there have been a few other molecules identified secreted by the fetus that may actually help trigger the onset of labor. One of those is pulmonary surfactant protein A, or SPA, which has been secreted into the amniotic fluid and has been shown to induce contractions. However, follow-up studies with transgenic mice that lack SPA resulted in normal gestation and birth of normal mouse pups. Thereby, if SPA is involved, it is not the only molecule involved. However, follow-up studies done only a few years ago with SRC1 and 2 seem to drive production of platelet activating factor, or PAF, which does appear to affect SPA release, and therefore the SRCs may potentially in some manner, potentially with cortisol and or SPA, collectively synergize to regulate parturition. Summarizing, contraction and relaxation occur concomitantly. They are both required for parturition to ensue in a normal fashion, and we know that both of those processes are driven by oxytocin and the prostaglandins. When thinking about contraction, we know it's predominantly in the upper fundus, in the upper segment. Concentrations of oxytocin, PGF2, and E2 all rise at term. The OTR, prostaglandin F receptor, and EP3 receptors also increase at term, and we find the highest concentrations in the fundus. We also see both EP1 and EP3 upregulated in the amnion, and we have multiple studies demonstrating that both OT and PGF can predominantly stimulate uterine contractions during phase 3 of parturition. Relaxation, we know, must occur in the uterine lower segment and the cervix to allow passage of the baby. We know that PGE2, working through the EP2 and EP4 receptors, will regulate relaxation of the lower segment and cervix. Interestingly, relaxin has been shown in many other species to cause relaxation of the uterus, but it does not appear to cause relaxation of the uterine myometrium in primates and non-human primates. It does appear to act predominantly on the suspensory ligaments to facilitate and help mediate relaxation of the myometrium. We also know that nitric oxide being produced in large amounts from the uterine arteries also helps with the relaxation effects occurring during parturition. We also know that binding of PGE2 with the EP2 and EP4 receptors is absolutely critical, and this will cause cervical relaxation and dilation. So now looking at the 3 stages of labor which occur during phase 3 of parturition. Childbirth is defined as the onset of regular uterine contractions, predominantly once they start occurring at least every 2 to 5 minutes apart. Key points: regular contractions are dependent on calcium flux. We know that oxytocin and PGF are the primary molecules which are stimulating calcium mobilization and, in essence, turning that syncytium of myometrial muscle into a contractile body. Remember the following points. There are 4 phases of parturition. There are 3 stages of labor, and the 3 stages of labor occur during phase 3 of parturition. Stage 1 of labor, we have the onset of regular uterine contractions. This is considered the onset. It's divided into both a latent and active phase. Regular contractions are now occurring 3 to 5 minutes apart. This stage ends when we have complete cervical dilation of 10 centimeters. It is during this stage of labor that the epidural is typically given to a woman giving birth. Moving into stage 2 of labor, we have rapid effacement and full dilation of the cervix. At this point, we have an increase in bloody show. The bloody show is where the cervical mucus plug has been broken down by the MMPs. This is now showing as effluent and discharge of tissue. A woman at this point will have a desire to push. There may be increased pressure on the rectum, and increased pressure on the rectum and within the entire lower abdomen may induce pressure on the diaphragm, and at this point in time, a woman may feel like she has nausea and or need to vomit. At this point in time, we now have the oxytocin receptors are upregulated, and it becomes a positive feedback loop. Recall that we have very few positive feedback loops in the endocrine system. 2 of them actually deal with oxytocin, and this is the first, the Ferguson reflux. Recognize that as parturition ensues, i.e. and or we now are into the active labor, that the uterine body starts to actually stretch. And as the baby starts to move through the birth canal, this mechanical stretching of the uterine body and cervix induces increased relay into the brain, and we have an upregulation of oxytocin receptors. These signals are communicated upwards to the PVN and SON, thereby leading to an increased release of oxytocin into the bloodstream. This increased oxytocin then binds with the increasing numbers of oxytocin receptors in the uterus, completing the positive feedback loop. Thus, the more stretch, the more oxytocin receptors are upregulated, the more oxytocin is released, the stronger the contractions. Stage 3 is the final delivery of the infant, which also includes separation and delivery of the placenta. Recognize here that Due to the delivery of the placenta, the major complication is maternal hemorrhaging, and in this country and many others, hemorrhaging during childbirth is still a major cause of maternal morbidity and mortality. We will now quickly summarize the changes that occurred during the postpartum period. So what are some of the highlighted changes? We'll recognize the key points is that the postpartum is technically defined as after delivery of the placenta. Most of these changes occur 6 to 8 weeks after delivery, but some changes occur slowly and take 4 to 6 months. Also note that these changes will be very dependent on each patient, and it will depend on how many children the woman has given birth to previously. So what are some of the typical responses and changes? Postpartum shivering due to blood loss and or temperature changes, also accompanied due to drastic reductions in hormones that were previously being produced by the placenta, occurs in 25 to 50% of all women. Immediately following birth and delivery of the placenta, uterine involution begins. Uterus will typically return to normal size by 6 to 8 weeks, and some women maybe even sooner. And recognize that pregnancy can physically occur after uterine involution is complete. The cervix will typically remain slightly dilated for 1 to 2 weeks. Complete normal cervical tone may take 12 to 16 weeks to return to baseline. Vaginal tone may or may not return to baseline at all. Okay, this will be dependent on each birth. Obviously, a large for gestational age infant will cause stretching and tearing of the vaginal tissue, and thereby vaginal tone may not return. Note that the average weight loss postpartum is 13 pounds, due immediately to the fetus and placenta. Most women do lose an additional 5 to 15 pounds postpartum for a total weight loss of 15 to 30 pounds after pregnancy. These weight loss changes may take weeks, months, or potentially even years. What are some of the typical hormonal changes observed during the postpartum period? HCG, which was being secreted by the placenta, plummets rapidly and will basically return to non-detectable levels anywhere from 1 to 4 weeks. FSH and LH, which were being clamped due to progesterone and estrogen acting on the hypothalamus, will remain low for 2 to 3 weeks after delivery and then return to their elevated levels. The ovarian hormones, which were under the control of very low levels of FSH and LH, will start responding to increases in LH and FSH, and those, in essence, will also start to return. Note here, importantly, that 70% of women, the ovaries will respond to those low levels of FSH and LH, and women will menstruate by at least typically the 12th week. However, a large majority of women can experience a fertile cycle before menses returns. Recognize that if FSH and LH levels return within 4 weeks, a woman may ovulate 6 weeks after pregnancy, and thereby 6 to 8 weeks after delivery, that woman can conceive. Prolactin levels, which recall were very elevated during pregnancy, will remain elevated for the first 3 months after birth if the woman breastfeeds the infant. Okay, and prolactin levels will then rebound, i.e. and fluctuate up and down every time a woman breastfeeds if she keeps breastfeeding after those 3 months, which we will discuss in subsequent slides. However, recognize that if a woman stops breastfeeding or does not breastfeed or cannot breastfeed, that prolactin levels will still decline faster, but they will exhibit higher variability in those women who do not breastfeed, as prolactin levels will decline, but there will be some fluctuation for at least typically the first month. Which leads us directly into the breast and lactation. At the end of this section, you should be able to identify the structures of the active and lactating breast, explain how the breast develops and what hormones regulate that, looking at the changes that occur in the breast during pregnancy and lactation, explain the mechanical, hormonal, and psychological interrelationships that regulate lactation, and then describe some of the processes of milk production and milk ejection, which are two very different mechanisms. This is a simple anatomical illustration of the mammary gland. Importantly here, recognize that the alveolus, demonstrated in the top right corner, is the active tissue in unit of the breast, and the alveolus contains ductile acinar cells in the center and is surrounded by myoepithelial cells. Recognize that the ductile cells, that the epithelial cells lining the ducts are going to be the cells that produce milk, and the contractile cells surrounding those epithelium are going to be the cells that are responding to oxytocin and causing ejection. So mammogenesis is the development and evolution of the non-lactating into the lactating functional breast. This will be a continuous process for the 9 months of pregnancy. Know here that during pregnancy, estrogen and progesterone are the primary drivers that are going to help develop the breast, with subsequent help from both growth hormone and cortisol, and obviously there's also some function of prolactin helping on the breast. Note that though originally identified as human placental lactogen, HPL was originally thought to also help augment growth of the breast, but we now know that the role of HPL is predominantly growth and metabolism, and it may augment some of the immunosuppressive effects exhibited by prolactin during pregnancy. Simple histology of the breast. Note here the extensive increase of the alveoli during pregnancy and lactation compared with the inactive picture of the breast tissue on the left. Predominantly, there are 2 stages of lactogenesis. Stage 1, which occurs during pregnancy, which is predominated by growth of the ducts and of the alveoli, and stage 2, which begins after childbirth. Stage 1 is lactogenesis, which is the second half of pregnancy. So we have initiation of the secretory components. The mammary gland at this point in time is capable of secreting milk, but the high progesterone levels suppress milk production and secretion. At this point in pregnancy, note that the gland is not secreting true milk, but instead it is making colostrum. So what is colostrum? Well, it's not your normal milk. This is a very special milk, and then it will be the first milk, and it will predominantly feed the child for 1 month, 1 week. It's rich in antibodies, rich in protein, rich in mild laxatives. It's also very low in lipids, low in carbohydrates, and low in water content. Okay. So recall that progesterone suppresses lactogenesis during pregnancy by blocking the action of prolactin on the mammary gland. So typically, during lactation, prolactin is going to act on those epithelial cells to induce the production of milk. However, progesterone blocks this, and it predominantly blocks it by blocking the prolactin receptor. So even though the concentration of prolactin is elevated, it is unable to act because progesterone suppresses production of the prolactin receptor, thereby inhibiting the ability of prolactin to stimulate stage 2 lactogenesis. We know that estrogen is also involved with this, and you may see in various review documents, Kaplan, etc., that estrogen and progesterone act synergistically to block the actions of prolactin. Recall that estrogen is required to upregulate progesterone receptor, and thereby it is both estrogen and progesterone that are blocking the actions of prolactin, but it is the direct effect of progesterone and not estrogen. Note that several hormones, as we've discussed, drive production of colostrum during the latter stages of pregnancy. So looking at lactation, there are hormonal, physical, and psychological regulators. So prolactin is the primary hormone that's going to stimulate milk production. We know that growth hormone, the IGFs, cortisol, and insulin are going to be needed to maintain the breast. And we know that oxytocin is going to act on those myoepithelial cells to induce milk letdown. Mechanical stimulation of the nipple will lead to the suckling reflex arc. Again, another positive feedback loop very similar to the Ferguson reflex arc. Nipple stimulation will also induce the release of both oxytocin and prolactin. Milk ejection is very complex, and we know that it's regulated not only by physical and hormonal cues, but also due to emotional, visual, psychological, and physical stimuli. It is, from a psychological perspective, poorly understood. So prolactin and oxytocin working in concert to stimulate lactogenesis and milk letdown. Point number 1, repetitive breastfeeding stimulates milk production, thereby creating a positive feedback system. Point number 2, lactogenesis requires prolactin, which is the primary hormone associated with lactation. We know that insulin, cortisol, GH, and IGF-1 are also involved. Point number 3, milk ejection is dependent on the physical stimulus, i.e. the infant suckling, and oxytocin. Point number 4, The suckling reflex arc stimulates both the release of oxytocin and production of prolactin. This stimulates milk secretion and subsequent milk production for the next time the baby suckles. Prolactin stimulates stage 2 lactogenesis and induces the onset of copious milk production. So during the postpartum changes, when a woman is breastfeeding, recognize that progesterone withdrawal and concomitant downregulation of PRs now permits prolactin to act. These prolactin-induced effects typically start 2 to 3 days after delivery, but may take up to 1 week. Mammary blood flow, oxygen utilization, and glucose uptake will all increase in the breast. This will lead to maternal increases in the secretion of insulin, GH, cortisol, and PTH, will help facilitate nutrient mobilization required for milk. This will lead to engorgement, i.e. and or breast swelling. So now that we've taken away progesterone, okay, this now relieves the block on prolactin to act. Prolactin, once it acts, is able to bind to the prolactin receptor, okay, on the epithelial cells lining the alveoli. This will directly lead to production of milk. Milk is going to be very high in lipid droplets. That milk is going to be stored in the alveolus. Now, once the infant suckles, this will stimulate the release of oxytocin from the posterior pituitary. Oxytocin will then bind to its receptor on those myoepithelial cells and induce contraction of the alveolus, which will lead to milk ejection. Note here that this diagram simply illustrates graphical changes in prolactin levels over time. We have the latter stages of pregnancy, followed by birth of the infant, and then approximately 12 plus weeks after birth. Note that after 12 weeks, suckling continues to stimulate prolactin secretion immediately or during the infant feeding. However, as the number of daily feedings are reduced, the basal concentration of prolactin typically falls to pre-pregnant levels between the feedings. Note here that levels will fluctuate from 12 weeks after birth until the baby is weaned. Weaning will occur anywhere from 6 months to over a year after birth. So, what happens when prolactin actually binds with its receptor? Milk production is actually quite complex. Okay, and the components of breast milk are secreted into the alveoli by 5 distinct mechanisms. We know that exocytosis is involved, especially for the aqueous components. There's reverse pinocytosis, whereby the lipid components are actually pinocytized and put into the droplets. There's transcytosis, whereby once the lipid droplet is formed, there's movement of proteins back and forth. We have apical transport, okay, which is limited to a very few select small molecules. And we have paracellular movement, i.e. a specific set of components found in the interstitium, including immune cells, i.e. maternal milk during lactation is a very complex, nutrient-rich fluid. So prolactin, recognize that the suckling reflex arc does not just involve oxytocin, but it also involves production and secretion of prolactin. So recognize that suckling inhibits the tide of neurons. Recall that prolactin secretion is under the tonic inhibitory control of dopamine, so that way when an infant suckles, there's actually a drop in dopamine secretion, which leads to an increase in prolactin production and secretion from the somatotropes of the anterior pituitary. This allows prolactin to be secreted in slightly higher amounts, in essence what would be considered bursts, and those bursts of prolactin are then able to act directly on those alveolar epithelial cells to stimulate milk production. Concomitant with that, we have the oxytocin arc, recognizing that suckling is going to stimulate directly the posterior pituitary to secrete increased amounts of oxytocin into the bloodstream. Once released, oxytocin will bind to its receptors and predominantly lead to milk ejection. Note here that during early in the postpartum period, the myometrium may exhibit some oxytocin receptors that are upregulated, and this may cause some feelings of contractility and movement, i.e., cramping of the uterus for postpartum women. However, this will go away relatively fast, typically within the first week, while the uterus is undergoing involution. So in summary, breastfeeding is regulated by psychological, mechanical, and hormonal stimuli. The graph illustrates relative changes in prolactin and oxytocin, typically during a single feeding. So mom hears the baby cry. This leads to a relatively quick increase in oxytocin, i.e. that psychological or auditory stimulus. The suckling will occur. While suckling, there is a large increase due to the mechanical stimulation of the nipple, large increase of oxytocin. This oxytocin will lead immediately to milk letdown, i.e. ejection of the milk. This will also lead to a subsequent rise in prolactin. This subsequent rise in prolactin will induce the next stage of lactogenesis, thereby allowing the breast to recoup and produce more milk for the next time the baby cries and needs to feed. So what are some of the breastfeeding difficulties and problems? They typically fall into two simple categories. Note here at the very bottom of the page, the first note, which is the vast majority of women manufacture adequate amounts of breast milk, i.e. producing breast milk is not the problem. Most breastfeeding problems are not caused by impaired lactogenesis. Rather, they are caused either due to psychological difficulties or inadequate oxytocin secretion, leading to engorged breasts and potentially infection, i.e. mastitis. Looking at category 1, the psychological difficulties, postpartum depression can be a major cause. Okay, this can lead to atypical release of neurochemicals such as oxytocin, i.e. and or increased levels of dopamine, which will block, in some manner, prolactin. There can be a lack of visual stimuli and or auditory stimuli. Note here that to overcome this, many women who go back to work will need to use a breast milk pump, i.e. because their breasts are engorged and they need to relieve the pressure. Many of those women will look at a picture and or recording of their child's voice, which will help stimulate milk letdown. The second category is typically due to inadequate oxytocin secretion or axin. Note here that prolactin typically works fine. However, this will lead to engorged breasts. Okay, the engorged breast also makes it difficult for the infant to suckle, and so this becomes a compounded problem that can quickly cause plugged milk ducts and mastitis. Note here that this is a poorly understood problem, and it is typically usually coupled with psychological problems. That is all we have for this independent learning.